clinical cardiologists or key clinical cardiologists, key physicians. So comprehensive consensus statement on INOCA management, incorporating contemporary evidence and drawing from this the valuable real world experience of Indian physician and cardiologists, whatever was the similar type of question. And I will just go through the results. Contemporary clinical practice should adopt a broader management approach to a stable CAD that better align with underlying cause of angina and ischemia. Coronary function testing enhances well-being for women diagnosed with INOCA. Nikoran with dual mechanism of action is effective for angina and patients with normal coronary arteries. The Likert score was 190. Nikoran is a preferred choice over CCD, calcium channel blocker and nitrates. Nikoran's unique action with cardiomyocyte protection make it a superior long-term choice. Mechanistically targeted approach improves prognosis in INOCA patients. Latest US guidelines for coronary artery disease are relevant for the Indian scenario that has the lowest Likert score. So conclusion. So finally reaching to the take-home message, patients with INOCA are underdiagnosed in daily practice. Adopting a mechanistic activation, mechanism-specific management can improve the prognosis of INOCA patient. Nikoran unique mechanistic activation of ATP-sensitive potassium channel, dilatation of coronary resistant arterioles that is less than 100 micron. Nikoran has proven effective in both coronary artery spasm and coronary microvascular disease. Guidelines EAPCI, ESC, ACC 2023 suggest consistent therapy with Nikoran as initial add-on strategy to vascular dysfunction that may warrant the consistent use of vasodilators and Nikoran. And concluding, patients with INOCA are underdiagnosed in daily practice. Because the presence of INOCA is associated with poor clinical outcomes, identifying INOCA and discriminating the underlying mechanism. I am again emphasizing that INOCA has many sub-endotypes, so discriminating the underlying mechanism are clinically very important. Invasive coronary evaluation with physiological assessment and provocation tests are needed to diagnose INOCA. Mechanism-specific management can improve the prognosis of INOCA patients. Thank you so much for your time.
Not written about any other drug for treatment. Isopropyl written as the treatment, which is hardly available. Most of the time we are using Giltiazine, almost all of us. So why did you write isopropyl?
Any DSP CCB is
so that is not important.
That is not agent specific.
And second,
you can use Giltiazine, you can use even amlodipine is being used as a vasodilator for that.
And second, if a patient got hypertension with angina, do we go for Nikoran or we go for other calcium or other drugs?
I told very clear words that it is an add-on therapy. It is not the. You have to start all the treatment is for the stable coronary angina like AC inhibitors, aspirin, statins. Aspirin is not very important, but statins, AC inhibitors, beta blockers, then add Nikoran.
And for ages, like we are old timers, we have been writing a diagnosis of atypical angina or atypical chest pain. I think should be very, very careful in writing that diagnosis now, especially with the advent of newer concepts and newer investigative techniques.
Right, sir. I fully agree that diagnosis of atypical chest pain or non-cardiac chest pain should be made only after excluding the INOCA.
This is a cardiac chest pain. This is not atypical or non-cardiac.
At least cardiac.
All the issue matters when everything was normal, you write atypical chest.
So that should not be
We should not write it now.
atypical is the symptoms that are happening. So if you have a typical symptoms as Dr. Vishal said, typical angina, then we should refrain from using the word atypical chest pain or non-cardiac chest pain because it could be. So as coming back to what Manoj emphasized that mechanistic diagnosis and mechanistic evaluation of INOCA patients should be done. But unfortunately, as Dr. Vishal has mentioned, these tests are still not widely available in our country. They are relatively cumbersome tests. But then specifically typical angina and a normal coronary artery, those patients should definitely be subjected to these tests wherever and wherever they are available. So the importance of having a specialized center, specialized professional who is looking into this may be a good idea. And secondly, but as Dr. Kuba mentioned, ultimately, since these tests are not widely available, we will have to go for empirical therapy only in those patients. But then again, the emphasis should be, we should not leave those patients as psychological or non-cardiac chest pain. If the symptoms are typical, we should be very pragmatic and we should start the treatment even if empirically then.
He has published more than 100 articles in medical and health journals. He was editor-chief of the Heart Journal, a bi-monthly journal, and he has authored 16 books. He is a regular guest faculty at national and various international on cardiology and heart failure for this hospital, Shalimar Bagh, New Delhi. I invite Dr. Pankaj has done 50,000 PTC and complex interventions, including rotablation, left vein bifurcation, IVOS OCT, and all, I think, latest interventional. Then he has done live case transmissions in India Live and NIC. He has been proctor for rotablation, Micra, and Max is the country's largest.
And this may be mediated through, KATP agonism, and this is much more pronounced effect in diabetic, as I said before. So what it does is that effect-wise, Nikoran will do vasodilatation, cardioprotection, reduces the endothelial dysfunction, reduction in atherogenesis, and platelet inhibition. So all in all, what you need in coronary syndrome, these all things are being done by Nikoran. So effect of Nikoran, and that is why cardiac protection, ischemic preconditioning would also be there. So it is the only angina that has shown some evidence of reduction in heart event, CV event among the patient with stable coronary artery disease and angina till date. So the hard endpoints are reduced. So what is the evidence on reduction of cardiovascular events with Nikoran, as Dr. Manoj elucidated, that we do not have such a wealth of data on this, but definitely there are quite a few papers on this. So if you look at this Lancet paper, that effect of Nikoran on coronary events in patients with stable angina, the impact of Nikoran on angina, this was a randomized trial, and if you look at the result, the coronary artery death, non-fatal MI, or unplanned hospital admission or cardiac arrest rate was decreased by 17%. All cardiovascular event went down by 14%, and rate of acute coronary syndrome also reduced by 21%, meaning thereby that unlike the nitrate data, this data is quite positive as far as the cardiovascular protection is concerned. Also, the Leona trial did show that the effect of Nikoran on coronary events in patients with stable angina, the impact of Nikoran on angina randomized trial And there also the anti-angiogenic therapy with Nicorandil in patients with stable angina significantly improves the outcome for reducing the major coronary events. So there, what had happened is that how does it do that? So here there is a K-ATP channel opener, thus dilates the coronary microvessels. So that is why it's an ideal agent in that setting. Reduces the preload and afterload also. Has an anti-anginal efficacy and safety profile similar to that of oral nitrates, beta blockers, and calcium agonists, and also it has potential cardioprotective effects also. Artery disease in Japanese coronary artery disease study, so this was more specific and more similar to our data because Japanese phenotypically will be more close to the Indian phenotypes rather than the Caucasian. So here the aim was to examine whether Nicorandil improved the outcomes of coronary artery disease in actual clinical practices. And this was fairly large trial, more than 2,500 patients were looked at, and primary endpoint was quite hard, that was all-cause death was looked at, and the secondary endpoint looked at was cardiac death, fatal mitral infarction, non-fatal mitral infarction, cerebral and vascular deaths, and other causes of death, all cardiac events and congestive heart failure. Reduction was there. It means that it's no mean achievement by this molecule. And when we look at the secondary endpoint, that was even more startling. The cardiac death was reduced by 56%, fatal mitral infarction by 56%, and 71% cerebral or vascular death. So, the 33% congestive heart failure reduction was also there. So in the Japanese population, for sure, it did miracles. So the conclusion of this trial